Thank you to the organizers for giving me this opportunity. And thanks, Prashant. Actually, he's taken away most of the pointers in the first session itself, so we'll be able to catch up on some time. This was a study published in 2021. It was a meta-analysis on lobar versus sublobar resection in the elderly for early stage lung cancer. So as Dr. Prashant had mentioned, in 1995, the only lung cancer study to trial RCT did show that there was a threefold increase in the local recurrence rates and a 75% increased risk of overall recurrence in sublobar resection compared with lobectomy. But it was not subclassified into segmentectomy oblique wedge resection. This is a difficult situation in elderly patients, especially with high risk factors. Hence, a lot of surgeons unfortunately also have moved away from lobectomy in such patients to offer alternative treatment options. One of the trials which he has covered is Japan Clinical Oncology Group, which was a RCT. Another one which is in process is a CalGB 140503. This particular paper aimed to actually analyze whatever literature is there and to see whether we can compare lobectomy with sublobar resection, including all the types of sublobar resections in elderly patients with stage 1 cancer, the primary outcomes being overall survival and recurrence. Secondary outcomes they covered was perioperative mortality, disease-free survival, and cancer-specific survival. They took all the literature from EMBAS, the Cochrane's register, the Cochrane Library, the PubMed, Scopus, and Web of Science from inception to 17th May 2020. The inclusion criteria included elderly patients defined as 65 plus with clinical stage 1 NSCLC who underwent either lobectomy or sublobar resection and reported the postoperative outcomes as mentioned before. The exclusive criteria was non-English papers, studies that did not segregate the outcomes based on lobectomy and sublobar, studies that lacked the critical and necessary data, case reports, abstracts from conference papers and commentaries, and with sample size fewer than 10. After all the inclusive and exclusive criteria were applied, they landed up 12 studies which were included in the quantitative synthesis of this particular analysis. It did show in a gist, it showed that except a 30-day operative mortality, perioperative mortality, everything else starting from 5-year overall survival, 5-year survival, overall recurrence, local recurrence, 5-year cancer-specific survival, and 5-year disease-free survival, all was lobectomy favored sublobar resection, except in 30-day operative mortality. For obvious reasons, it's an elderly patient with high risk factors and a bigger resection. This in these subset of patients, lobectomy proved to be a less advantageous kind of thing. 5-year overall survival, local recurrence, as well as a 5-year disease-free survival, all of these three, lobectomy had a significantly less risk of death. But when they analyzed in the subgroup analysis, they did see the 5-year overall survival in stage 1A tumors. There was no statistically significant difference in the 5-year survival between the lobar resection versus the sublobar resection, which was not the case in 5-year overall survival in stage 1B patients, wherein lobectomy had a 66% lower risk of death. So this in their meta-analysis definitely showed that patients who are elderly, high risk, and who have stage 1A NSCLC, they can be easily given a sublobar resection rather than a lobectomy, and that those patients can benefit from surgery. There was no publication bias in this meta-analysis. The pointers which they covered and they highlighted were, since stage 1A has no significant difference, so suggestion was for patients with stage 1A cancer, sublobar resection is a viable alternative in high-risk patients. Sublobar resection for larger tumor sizes obviously leads to decreased resection margins, so higher risk of recurrence. There was rather a lack of discrimination between segmentectomy and wedge resection, which is now getting more streamlined. There is spread through air spaces, which is impact frequency of recurrence. It does impact the frequency of recurrence after limited resection for stage 1 lung cancers. Hence, they did suggest that in elderly but otherwise fit patients with stage 1B onwards, lobectomy is still preferable. Limited resection obviously leads to less postoperative morbidity and mortality compared with a lobectomy. Hence, it has a better 30-day perioperative mortality. Hence, sublobar resection is still justified in elderly patients with increased comorbidities and poor lung reserves. The limitations of this trial were all but one of the studies which were included were retrospective in nature and with no RCTs available. Different definition of elderly varied from paper to paper, and there was no differentiation between wedge resection and segmentectomy, and they were not specifically separately defined in the literature taken. The study concluded that lobar resection is superior to sublobar resection as per the survival and local recurrence in stage 1 lung cancers. Hence, if clinically feasible, elderly patients should still be offered lobectomy. Subgroup analysis did show and prove stage 1A tumors. Sublobar resection is non-inferior for OS, and as Dr. Prashant has also mentioned about the RCT, he has gone into depth that if it's a segmentectomy, it is actually proven to be quite good in 1A. Further RCTs are required to justify sublobar resection for elderly patients, and it's a tough ball to roll. Thank you. Any questions?
So, any questions? Thank you, Dr. Priya.
Thank you, sir. Sublobar is sublobar resection has got wedge resection, segmentectomy, 2 segmentectomies, so multiple things, anything which is less than a lobe. So currently sublobar resection for stage 1A, and if I listen to the first lecture first, I would do segmentectomy in those patients. Thank you.